me? Do you know how to put this in? Yeah, PowerPoint. Yeah. How do we? I'm trying to go where they see this, not this.
Oh, okay, let's see. Try to do. I think it would be presentation view.
Where is that? Here?
Yeah, try that.
I'm doing it. It's not doing it. No, I'm not sure. Hold on, guys.
Yeah, you're not sharing right now.
Yeah, right.
Okay.
Hold on. Let me go back.
Oh, that should be it.
Yeah, it is, but it's not. When I share, they see this.
Oh, you got it. It's good now.
Can they see? I don't know.
Yeah, they can see this.
Denise, I think your slides are showing now in slide mode. We lost you.
Do you need presentation notes?
Yeah, that's what I want. Well, no,
Oh, okay, try that.
share.
Yeah. And then do that at the bottom. Yep.
Yeah, I guess it's not for me.
Is that?
But then they see this. It doesn't matter. It's okay. All right. Thank you. Babe. No. Okay, we're gonna go. It's okay if you see the next slide. It's all right. So you see both slides, our mission and the first one, correct? Okay, thank you. All right, so our mission is to save and enhance lives through organ and tissue donation. We honor, we remember, and we give hope. Every day we work hard to save and enhance lives through organ and tissue donation and provide support to families of those who give the gift of life. Every day we work to save and enhance lives. Sound familiar? That's what you guys are going to be doing. Saving and enhancing lives. You're going to play a big role in just your everyday patient. You're going to make a difference to that family. You're going to make a difference to that patient. So always remember that. And we do the same for those who gave the gift of life. So ensuring the integrity of the process. We are in all the hospitals. We cover every hospital in New Jersey, except one that is all the way down to the end of New Jersey. And it just makes sense for the Organ Procurement Organization in Philadelphia to cover that hospital because of the distance. So from the northern top of New Jersey all the way down to that hospital, we cover that one. So what it is every state has an organ procurement organization. We are from New Jersey. There's Gift of Life in Philly. There is Live On New York. Some states are so big, they have more than one, like Texas and Georgia. They have more than one. But we cover New Jersey. And we are open 24 hours a day, 7 days a week, just like a hospital. So we have to ensure the integrity just like the hospital, but we do it for our process. And we report to regulatory agencies like a hospital, CMS, FDA, the Joint Commission, and the United Network of Organ Sharing, just to name a few. So we are highly regulated, federally funded, and we definitely want to always ensure the integrity of the process. So here's a couple of things that you all need to know. Center for Medicare and Medicaid Services, hospitals, conditions of participation. Organ donation. All intimate deaths are referred within 1 hour. Are there any questions about that? Tissue donation. Every death is referred within 1 hour. Every approach must be done by the New Jersey Sharing Network staff. I always give this analogy. Say you have Tom and Sally. They're married. They woke up this morning. They're hustling and bustling around the house to get the kids ready, get everything together so they can get out the door, go to work, go to school. Honey, what do you want for dinner? Oh, I don't know. We'll talk about it later. Okay. And something happens. And now one of them is getting a phone call that they have to rush to the hospital. They get there, they see their spouse connected to all types of machines. Doctor comes in and gives them the grave prognosis. Something has happened. Their loved one is not going to make it. Do you think that same doctor should start talking about organ and tissue donation? So I need you to unmute for this. Do you
No.
think so?
No.
No.
Exactly. No. We work with our hospitals. They are partners, but we are separate. So we approach a family and we're solely responsible to determine medical suitability. Every family must be offered the opportunity for donation if their loved one is medically suitable. I have seen families who are distraught, distressed. It is a terrible situation. But when we go in to offer what their loved one can do, how that loved one can save a life, enhance a life, it doesn't take away the grief, but it turns into something else. And that's what a family is looking for. That's something else that would give some type of hope, some type of glimmer, some type of faith. And that's exactly what organ and tissue donation does. So every family must be offered the opportunity if that patient is medically suitable. Are there any questions? Right. So how many people do you think are waiting in the United States for a life-saving gift? Throw out a number. Give me 2 people. Throw out a number.
A few
Come on.
hundred.
How many?
A few hundred.
That's not a number. Come on. Come on.
1,000.
1,000. Okay. Somebody else give me a number. We're talking the United States. Give me another number.
30,000.
30,000. Thank you for trying. It is 100,000 people waiting. And when I look at that, I see 100,000 patients, people who are sick, people who are waiting. But how many of you have ever had family members and loved ones who were sick? You were thinking about them, you worried about them, you sent up good vibes for them, you prayed for them. So it affected you. So it's more than 100,000 when you think about the people that wait with the people who are waiting. How about New Jersey? How many people you think waiting in New Jersey? Come on.
5,000. 10,000.
Okay, I'm loving the numbers. 4,000 people waiting in New Jersey. 4,000. And some of you may know someone who's waiting. You may know someone who has gotten the gift of life or given the gift of life. All right. One organ and tissue donor can save up to 8 lives and enhance the lives of 75 or more. And it's really 9 if we split the liver. But in total, one organ donor can save up to 8 lives. So let's talk about the organs. You have the heart, the liver, 2 kidneys, 2 lungs, pancreas, and intestines. So if we split the liver, it can be 9. How about living donation? What can be donated when you're alive?
Kidney and liver.
Kidney and liver. Yes, part of your liver, because the liver does what?
Regenerates?
Right. The liver regenerates. And of course, one kidney, because you can live fine with one kidney. Okay.
Bone marrow?
No, we don't facilitate bone marrow, but yes, you can donate bone marrow. Absolutely. Absolutely. So, as amazing nurses, this is the organ donation referral process. Ventilator dependent patients. If you have a patient that's ventilator dependent, if they meet any of these triggers, you have to call us within 1 hour, regardless of age or diagnosis. You cannot look at a patient's chart and say, oh, my patient's 91. I'm not going to call it in. Because who makes medical determination, suitability determination? Who does that?
The sharing network?
Absolutely. That is right. So, Glasgow Coma scale of 5 or less, loss of 2 or more brainstem reflexes, or the family's discussion about end of life options. And as a nurse, family comes to you and says, hey, what's next? What can we do next? Your response should be, someone will be here to talk to you about next steps. Okay? Any questions about that? And it's a ventilator dependent patient. So when you're out and about after today and a family member or someone you know says, oh no, not putting that on my license, they're going to find me and take my organs. Can't do that. Got to be in a hospital on a respirator or a ventilator. Okay? Any questions? All right. Tissue that can be donated. Go ahead.
Question?
Yes.
It's everyone is approached, or do they first find out if they are, because you're saying that they're approached whether they're organ donors, like on their licenses or not?
Right.
Got it. Okay.
That's correct. Yes. But we got to make sure they're medically suitable, because we would hate to approach a family and the person is not medically suitable. That's really giving them hope and then taking it back. And we don't
Okay.
want to add salt to the wound. Good question, though. Yes. Yes, we do approach. And, it's a different approach, because one is a notification, because 9 times out of 10, that conversation never happened. The person didn't even know their loved one was a donor, registered donor. That's why it's very important to have this conversation with your family, whatever your choice is. Okay. So, tissue that can be donated. We have bone, cornea, skin, tendons, valves, and veins. Bone all of these can be stored over time. Bone for different bone replacements. They're starting now to use it in dental surgery, where they grind it down to a powder, much more healthy than the metal that they used to put in your mouth. Cornea is not the eyeball, it's like the contact lens over the eye to restore sight. Skin for burn victims, children who have cleft palates, women who need reconstructive surgery from breast cancer, mastectomies, tendons for sports injuries, valves and veins for surgeries, dialysis patients. So tissue does so much. And like we said, it enhances lives, but sometimes it saves lives. Okay. Any questions? Any questions?
Are people more reluctant to donate tissue because they're worried like how it'll make the body look, or the families don't
Good
really
question.
care?
Very, very good question. When our family services departments sit down with a family, we do explain that. And hopefully they have the question that you just asked, so that we can tell them it is done very respectively. If it is tissue, if it's skin, comes off the back. You can never walk up to a remains and tell the person was an organ donor. If the family wants short sleeves, of course, we would never take anything off the arms. So it's a conversation. It's a conversation with a family. That was a good question. Thank you. Any more? Love them. Keep them coming. Keep them coming. A tissue donation referral process. All deaths are referred to us within 1 hour of potential tissue donation screening. So the RN from the hospital refers the patient because they've met those clinical triggers. And then we determine medical suitability in collaboration with our tissue partner. And then the approach, it's done and it's initiated by the sharing network. And tissue must be recovered within 24 hours of death. Any questions about tissue? Okay. A lot of people don't realize that once you put, like me, when I got my driver's license, I thought automatically, hey, when something happens, I'm going to be an organ donor. It is a very, 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 very rare gift. Less than 1% of all deaths meet the specific medical criteria to be organ donors, and less than 10% for tissue donation. Are there any questions about that? For any questions, remember you have to be on a ventilator. It could be previous medical issues, even down to tattoos. When did your loved one get this tattoo? Oh, 3 months ago. Can't take skin. So there's so many things. Most people that sign up, register, won't be donors. Okay, that's why we have 100,000 people waiting, 4,000 in New Jersey. Does that make sense? Anybody have any questions?
I have a question. Why do they have to be on a ventilator or respirator? Because like a lot of people aren't when they die.
Well, then they wouldn't be suitable for organ donation. Because what does the organs have to have to stay perfused?
Like oxygen, like otherwise the
Exactly. Yep. Good question. Yes, they have to be on a ventilator or respirator. Now, if they pass away in a hospital within an hour, then we can recover tissue. Okay.
I would like to share something.
Okay.
Hi.
Hi.
I just wanted to share something. We had a patient when I was on my externship that died from 1 minute to the next. They just like went to the bathroom and died. And my nurse ended up calling the sharing network and they came down to speak to the family like right away. And it was really nice. They gave the support to the family, discussed options and all that. It was nice to see them.
Yeah. We have so many departments here. Thank you for that. We have so many departments here that support families. Our donor families don't leave us. They may kind of go away for a little while, but they're back because they know their loved one gave the gift. And they want to stay close to us because that's staying close to their loved one. So yes, we support families at the worst times of their lives. If by chance they say they don't, the loved one is not registered, and we sit and talk with them and answer their questions, and they still say no, we don't leave them. We still support that family, try to help them. So it's not always about the yes, it's about the gift. And that gift can be organ and tissue donation or just our time to a family. All right, so there are 2 pathways to organ donation. Donation after brain death and after cardiac death. Brain death determination by neurological criteria, adults 18 years of age and older, 1 clinical exam showing no neurological reflexes, and an apnea test. Pediatrics less than 18 years of age require 2 clinical exams. Are there any questions? Any questions? Okay, then there's cardiac death. Donation after cardiac death, a procedure whereby organs are surgically recovered following pronouncement of death based on irreversible cessation of circulatory and respiratory functions. Family makes the decision to withdraw care and allow natural death to occur. We are notified before withdrawal occurs. That is something I want to stick out in your head. We are notified before withdrawal occurs. Okay. We approach the family for authorization, and withdrawal occurs in an OR designated area. If the patient is declared by cardiac criteria within a determinate time frame, then there is rapid recovery. Does that make sense? Any questions?
I have a question. Do you ever find that patients actually get better, like when they thought that they wouldn't?
No, unfortunately, if they've been declared brain death, we know there's a difference between coma and brain death. So unfortunately, no. Even after cardiac death, the body automatically does things, just does it. And then it doesn't. So no, we have not had an instance where a patient got better once they got to this point. Any more good questions? All right. Then there is preparation for the conversation. We determine medical suitability. We discuss with the we discuss with the healthcare team to create a plan to maximize the gift. And you are a part of that healthcare team. We just got on site. You've been with that patient and that family longer than we have. So we really rely on your assistance to tell us about the patient family dynamic and those type of things. But we include you on that, creating that plan. We ask for lab work requests, and we collaboratively discuss a plan for approach. That conversation is done at the right place, the right time, and by the right people or person. And of course, that is the New Jersey Sharing. A lot of people ask this question, well, if it's on my license or I've done it on, it's on my will or the app on my iPhone, can my family decide against it? It is a legal binding document. You made that decision when you were alive and well. If I decide to give my brother $1,000 and give my sister $100, she's not going to be happy, but she's going to get $100 because it's in my will. Okay. So you can register on your driver's license, the online registry, your advance directive, your living will, and even on your iPhone to be a registered donor. Are there any questions?
I have one.
Yes.
So if on your license you aren't a registered donor, your family can still say that they wish to donate everything?
Yeah.
But then how is that not
Because you didn't put it on. A lot of people don't put it on their license. They want to be, but sometimes they're afraid that, they're not going to save if I'm that sick. But if I get that sick and I can't come out of this, then donate. That's all about a conversation. Thanks, Gabby. That's a good question. It's all about a conversation. Yeah. Any more questions? So recovery. Go ahead. I hear somebody. Question? Okay. Recovery. We utilize the hospital's OR or designated location. There's a calm environment and moment of silence. Remember, I told you about our family services department. We sat with that family, and they know that John likes the Mets, and we will play for the family a Mets game during recovery. They like Mozart. We'll play Mozart in that room where that surgical recovery and reconstruction is happening to honor that loved one. Our family services department goes in and tells that staff exactly who that person thoughts, what they like, things that their family said about them. So all of that is done in that same room, the recovery and the reconstruction, and the medical examiner and funeral home will receive the remains afterwards. Are there any questions? All right. We honor the gift. It's a big thing for us to honor the gift. That top left picture is St. Barnabas in Livingston, lit up in blue and green. Some of our hospitals have flagpoles. We will fly the flag like you see in the middle, or when they have a donor, they light up in blue and green. That picture was taken by a young lady named Yvette. Her father became a donor, and as she was walking out of the hospital, after they took him to the OR, they lit the hospital up in blue and green. She, at the time, was in school to become a police officer. Well, after her father's gift, she is now a HD, which is a hospital director for the Sharing Network. She changed her path, her career, and she says her dad brought her here. The bottom left is the names of, we have this going all the way around our building from 1996 to present, and it's updated every few months with the names of every donor. So families can come in, see their loved ones' names on the wall, and it is just a beautiful way that we honor, and we get to see every day when we come in that we are honoring those people and why we do what we do. The top right, that is our beautiful quilts that we have around the office. Our families are able to decorate quilt squares, give them to us, and we make those beautiful quilts that just as another testament. The bottom right is our meditation garden right here at the Sharing Network. It is a beautiful place. There are plaques in there for donors, and it's just a quiet, serene place where families can come. We go there. The neighborhood goes there. Deer, rabbits, everybody, everything goes in this garden. It's a beautiful place. We have the falls open now, so you have a running brook. So it's really a really nice place. You all are definitely invited to come out. I know you're a little far, but come on up. Come up North Jersey and come see us at the Sharing Network. You're always welcome. So follow family support and follow up. Support and communication, connecting families. We have quilts of love, as I spoke about. We even have a program of volunteers that knit and crochet for us. So it's called Wrapped in Love. And you can go on our website if you'd like to be a part of Wrapped in Love program. It is amazing. So we knit and crochet those beautiful lap blankets and that shawl that lady has on right there. And we give them to our donor families 2 years after the gift is given. We connect families if both sides want to meet, the donor family and the recipient. We connect them together. And of course, our amazing family services department has all type of grief counseling and different ways to support families. So things to remember. Refer all vent patients meeting any of the clinical triggers for the evaluation of organ donations, such as GCS or 5 or less, Glasgow Coma Scale, loss of 2 or more brainstem reflexes, end of life discussion. Refer all deaths for evaluation of tissue donation. And the donation conversation should be by the New Jersey Sharing Network staff. Any questions on that? Social media. We are on all social media platforms. So please go on. Check out our website this month. It is National Donate Life Month. We have so many things going on. You will soon see our. Yes.
I'm just curious, how often do you have organ donation? Like, is it on a daily basis or it's something that is?
It can be on a daily basis. Yes. Depends on, the outcome of, how a patient is doing, if they're even suitable. So yes, daily.
Okay.
And then there's some days we don't, because we get 3 referrals and those patients aren't suitable. So yeah, that's why we ask people to register, just register and have this conversation with your families. If, people don't register, still have the conversation with your family. You know more now than you did when we started this presentation. So we have a new commercial out. We have 2 new commercials out, first time, about organ and tissue donation. So please check those out. We're on most stations, most, Roku, we're everywhere. But we're all definitely on social media. Please follow us, like us, start a conversation, check out our website. Any questions? Any questions?
I have a question.
Sure.
Do you work with every hospital in New Jersey?
Every single one of them.
Okay.
Yep. Good question. Yes. Any more questions? And please check out our website for employment opportunities.
I have a question also.
I'm sorry.
Question also. Do you hear me?
It's hard to hear you.
Do you hear me now?
Yeah, you sound a little muffled, but go ahead.
I was just wondering, for a nurse that works in that ICU environment where a lot of patients are, eligible for releasing, whose job is it to pay the referral? Is it the nurse or the provider?
Can you type your comment in the chat? Because it's hard to hear you. Yeah, if you would type that, that would be great.
You're very muffled. No one can understand you.
Yeah, so type that for us, because I want to hear what you're saying. So I told you at the beginning how much I love nurses. I just think you all have wings hidden underneath your scrubs, and you are just amazing. I truly think that nurses are angels, definitely, because this is me. This is me almost 19 years ago. I received a double lung transplant. And after a very long surgery, going to the ICU, being sedated for 5 days, when I opened my eyes, there was a nurse in there. She told me the best news I heard in many, many, many years, because I was on oxygen for many years. She looked at me and she said, "Well, welcome back. So good to have you back. Everything went well. We want you to just get stronger and use those new lungs." And I reached up to touch my face. She said, "Oh, you're looking for the cannula, huh?" And I shook my head, yes. She said, "Well, yeah, there's a tube and the cannula is there." And she looked at the monitor and looked back at me and said, "But Miss Peoples, you're pretty much breathing on your own." Had not heard those words in years. I was diagnosed with idiopathic pulmonary fibrosis. And it was a journey. It was a journey going from a very active person. I mean, always something going on, going here, going there, to not being able to do anything. I had to think about going to the bathroom. "Okay, Denise, you got to stand up." I would stand up and be out of breath. My whole left lung was fibrosed. The bottom of my right lung started, and I was in need of double lungs, or I would not be able to present to how many of you are on here? 40 of the most amazing people on the planet. Any questions about my journey? No questions off limits. We family now. We've been together longer than 5 minutes. So you can ask me any question.
Denise?
Mhm.
I'm blown away. That's so beautiful that like your whole presentation, just hearing that is like beautiful.
Thank you.
Really
Thank you so
beautiful.
much. Thank you. I wasn't doing this before my transplant. I was working as a legislative chief of staff for the state of New Jersey. And while I was home recuperating, I was like, okay, I know there's a transplant center because I was there. And I know, unfortunately, there was a donor. Who's in the middle? Like, who does this? And I Googled and Sharing Network popped up. I said, oh, you know what? I'm going to volunteer. When I go back to work, I'm going to volunteer. So I volunteered for about 5 years. And then they offered me a position. And I've been here ever since. So for 14 years, I've been here. And
Makes the whole presentation that much more meaningful.
Oh, thank you. Thank you so much. I appreciate that. And when I tell you, I must say, even after 19 years, I think I had the best looking surgeon ever. He's still handsome after 19 years. Pulmonologist is looking pretty good. He looks good after 19 years. But they went home every day. Those nurses did not leave me. That's why I think nurses are angels. 3 o'clock in the morning, I'm having an anxiety attack. It's a nurse that came in to check on me. and did little things to help me. So yes, I am partial to nurses. I am. So any other questions? Any other questions? So we have 2 5Ks, guys. One in May, down at Ocean Grove. I know you all know where that is. Please join us. Check out our website for dates and times. If you want to come as a team, you can. We walk, we run, we dance, we celebrate. It is more than a 5K. It is a celebration of life this year. We are celebrating 15 years of our 5K. So please come join us. And if you want to take a little trip, come on up to North Jersey in June. We have one here on our campus, about 10,000 people. It is amazing. And I get to do something that I started doing when I was a little girl, and that is singing, which of course, all of that stopped when I got sick. I sing the national anthem at both 5Ks. So please come to one of them and walk up to me and let me know who you are and where you're from. And we can dance together. So I appreciate you. Always remember, without the organ donor, there's no story, no hope, no transplant. But when there is an organ donor, life springs from death, sorrow turns to hope, a terrible loss becomes a gift, and I get to present to angels. I want to wish you all the best, the best. I want to go in right now and see this question. As an ICU nurse, where many patients may be eligible for donation, is it the nurse's job or provider's job to put in for the referral? It is usually the nurse that does that because they meet those clinical triggers, and the nurse is usually the one who sees that. Sometimes it may be, a doctor in there, but yes, that's where our referrals come from. We have a center here called the DRC, Donation Resource Center. 24 hours a day, 7 days a week, they are there. The nurse would call into there from the 1-800 number. That's pretty much at every nurse's station. Nurse managers have the number. You all will have the number. Call in and they will walk you through every single step. Okay? Great question. Thank you, Miriam. Any other question?
Yeah. Any other question? I have a question, Denise.
Yes. What's your question?
So I have a colleague whose husband is waiting for a kidney,
Okay.
and she is not she is not a match for him.
Mhm.
But she was telling me that she is going to donate to somebody else. Would that put him higher on the list?
I am not sure about putting him higher on the list.
Mm.
She, God forbid something should happen to her after she donates a kidney as a living donor, and God forbid something should happen one day down the line and she needed a kidney, she would go to the top.
Oh, okay.
But the exchange happens, I think, more lateral.
Oh, okay.
And that's what that's called, an exchange. So she donates to someone else, somebody else will be able to donate to her husband, and it's a whole process, and that chain can go on and on and on. Sometimes the chain can be 10 people, sometimes the chain can be 40, 50, 60 people. So that is an amazing thing about living donation. Yeah.
Great. Thank you.
Any other questions? All right. Well, I wish you all the best. I will be rooting for you. I know you'll be fine. Remember that after graduation, those badges are going to have RN on them, and you deserve it. You worked hard. Registered nurse will be your title. But remember, to families, those patients, that RN means really necessary. So thank you all so much for joining me, and have a great day. And remember to breathe easy. I hope to see somebody at the 5K, one of them. Come and see us. Check out our website. Don't forget, check out our website. If you have family members who are in the field but not as advanced as you are yet, please let them make sure they check out our website. We have a new health sciences scholarship that will help people in the health field financially. So thank you so much for joining me, and have a great day. Breathe easy.
Thank you so much, Denise.
You're welcome, everyone. You are welcome. Thank you, doctor. I appreciate you. Always
Yeah.
good to see you.
I appreciate you as well. Thank you.
All right.
Thank
All
you
right,
so
Dr.
much.
T, take care.
Have a great
Bye-bye,
day.
everybody.
Bye-bye.
Take care.
What did you think? Did you?
It's wonderful.
Yeah. So,
Very-
the important thing is that it's your responsibility to contact Sharing Network. If patient meets criteria, you may want to talk to your nurse manager first or the charge nurse. But nurses make the call. And then the other thing is that you don't have the discussion because the people at Sharing Network are trained to, know how to be sensitive and do that discussion with the patient. You're there to support the patients and the family, but Sharing Network should be doing the actual discussion with the patients. So very good. We met our criteria for you to now be able to go and take your NCLEX according to the Board of Nursing. So we're happy about that. And I am waiting for our next speaker. So let me see if she's in our list. So it looks like she hasn't joined us. Take a 5-minute break and be back here at about 10 to 10.
Thank you.
I was on mute and talking. I gave them a 5-minute break, so they'll be back at 10 to. Everyone will be back.
All right,
Okay.
perfect.
I didn't realize you were in the waiting room.
That's
I
okay.
am
No worries.
sorry. How are you
worries.
doing today?
Good. I sent you new dates for the podcast.
Oh, okay, good. I'll look at them. When are they? In August?
Yeah, August, September.
I can't believe the 2 weeks they sent are the ones that I'll be on I'm waiting to see.
Yeah, I explained the whole thing to them and she just gave me new dates. So
All right, great. And April's coming back.
I know, 22nd, but who's counting the days?
Oh, I think it's
Sooner?
Yeah, Friday. I think she's taking Friday off. Hopefully she'll be at our meeting on Monday.
Oh, that's great. I didn't realize that.
Yeah.
Good. We need her back.
I know. Definitely. have to answer Avery too about the QI
I know,
versus research.
I know.
Very confusing.
Well, if you have time to talk today, give me a call.
Okay.
I'm available. I have an 11 to 1 and then a 3 to 4, but otherwise I'm available.
Okay. I can call around 1, I think.
I think, you know, to be honest, if I was reviewing that, I would have never approved to go to non-human subjects.
No.
But my thinking is more on protecting the patients and the nurses than on qualifications for IRB.
I didn't read that one. So that was a research study you felt? And they approved it as QI?
Right, because they said their intent was QI. And it's really, I think it's an evidence-based practice project. But there's a great burden on the nurses giving out MP3 players. Are they approved MP3 players? Maybe I have too much of a research lens, but in honesty, you know, it's not research. So, you know, that's the lens that the IRB is coming from. It's not a systematic investigation.
Okay. So if they say they're a QI, we need to believe them and just say, all right.
But they all say that.
I know, because that's what their schools are telling them.
And how do, you know, patients are sick with cancer already. It's a cancer unit. What if I don't want to participate? I want to be sure that they have that option. Maybe I'm too controlling.
Okay. All right, is everyone back? If you are, please turn your cameras on.
Wow, this is a big class.
Yeah,
40
we actually have 2 classes here, so.
2 classes. Wow. And what year are they? They're getting ready for graduation or?
They are graduating how many days, ladies and gentlemen?
Who's counting?
Oh, I'm sure you know how many days.
8 weeks.
8 weeks, okay.
Wow, that's exciting.
I don't know, other classes tell me by the hour, how many hours they have to graduate.
I think it's around 35 days, but I don't know the exact number because it's like a month plus like 5 days, something like that.
Oh, okay. All right. That's close. That's good. Everybody back. All right. We will get started. It is my pleasure to introduce Dr. Sue Weaver. Dr. Weaver is a nurse scientist at the Ann May Center for Nursing at Hackensack Meridian Health. We work together. She also works for the New Jersey Collaborating Center. She's a prolific researcher and presenter and has many publications. And she's going to talk to you about the importance of joining your professional organizations and also what's going on in nursing around the state and the country. Dr. Weaver?
Yes, can you allow me to share my screen, Terry?
Oh, yeah, sorry.
That's okay. Good morning, everyone. It's a great time to be in nursing. We're having a nursing shortage, so great time to enter the profession. Oh, looks like we have a little future nurse with us, too. So cute.
Okay. All right, you should be able to present.
Okay. Okay, so Terry already told you about myself. And this is what I'm going to talk about essentially. Just talk about the New Jersey Collaborating Center for Nursing, which is our state workforce center. And we're very fortunate that nurse leaders in New Jersey had the vision to establish a workforce center because not all states have a state nursing workforce center. And then I'm going to talk to you about New Jersey State Nurses Association and legislation that impacts you as future nurses. And if you have any questions, just unmute yourself and ask me throughout this, okay? It's hard for me to watch the chat when I'm presenting, so that would be best. So as I said, we had visionary nurse leaders way back in 2002 that got legislation approved to establish a state workforce center. And the purpose of the workforce center was to address issues of supply and demand in the nursing workforce, including education, recruitment, retention, utilization of adequately prepared nursing personnel. I'm not going to read all my slides to you, but I just thought this slide is pretty important. And so there was a bill presented to the New Jersey legislature, and it was passed to establish the center back in 2002. And then a number of years later, another bill was passed, an addendum really, to allow for funding of the collaborating center. So when you become an RN in New Jersey, a percentage of your licensing dues goes to fund the work of the center. And the collaborating center, in that legislation, it says the collaborating center should have a 17-member board. And the nurses on the board are appointed by the president of the Senate, Speaker of the Assembly, or governor. And do you recognize anybody in this photo?
Dr.
Yeah, Dr.
Wormser.
Wormser.
Yes.
Second from the right.
Yes, she was appointed. The way it works is that the nursing professional organizations have to recommend nurses to be on the board. And in Dr. Wormser's case, it was the New Jersey State Nurses Association that recommended her. And then I believe she was appointed by the president of the Senate to be on the New Jersey Collaborating Center board. And she was is still an active member of the board, of the Collaborating Center board. So this is one thing that we do at the Collaborating Center, and I think it's just interesting for you as future RNs to know about this. We collect data from all the schools in New Jersey, and we also collect data from RNs, LPNs, and advanced practice nurses when they renew their license. They get part of the license renewal is answering questions about where they're working and that sort of thing. And I'm just going to share some of the results with you. And now this report comes out yearly. So the data I'm sharing is our 2025 report. And that encompasses different years. The education report is the 2022 to 2023 academic year. And these are the various nursing programs we have in New Jersey. Were you aware there are still 5 diploma schools? And then 22 BSN programs, one of which is Georgian Court. And were you aware there's 3 pre-licensure masters in nursing programs? And I believe Georgian Court is one of them also, where your entry level, you can get a master's degree as your entry level nursing education. And we also have 3 PhD programs, which I would highly recommend sometime in your future. So now I have just a few questions for you. So what do you think about this? Are there more associate diploma graduates or BSN graduates in New Jersey in this latest report?
BSN.
Okay. Is that the rest of, what do the rest of you think?
I think now more people are doing BSN. It
Okay.
used to be more associates, but
Okay. Well, let's see what the numbers show. The numbers show it's very close, but if you count diploma with the associate degree, there are more associate degree and diploma than BSN. I think last year it was a pretty even split. Now, this is a slide that I think you might be interested in too. We also gathered data on how long did it take you to obtain a job after graduation. And look at this, pretty encouraging, right? You're not going to have trouble in this day and age in finding a job. Is that encouraging? Do any of you have jobs already? I see one person nodding their head. I can't see many people. I remember when I graduated, it was also a nursing shortage, and I had 3 jobs. It was really hard to decide. But that's a nice place to be in, right? Okay, so this slide just says what's our post-licensure graduation trend. And you see here that it is good news that even though a lot of nurses have an associate or diploma, many are going back for their BSN. And look at the number of DNP graduates versus PhD. Remember that when you're thinking in the future. Lots are going for their DNP. Very few going for their PhD. And these low numbers with PhD have been pretty consistent over the years. And I'm just quickly talk about nurse faculty. We do have a shortage in nurse faculty in New Jersey, which is similar to the country. And why is that important for nursing? It's important because if we don't have enough faculty, schools will not be able to accept as many nursing students, which will potentiate the shortage. So think about a career as a nurse educator in your future. I know you have some great faculty at Georgian Court. Now so that's basically the highlights from the education report. Now we're going to get into the workforce supply report. Like I said, we partner with the Board of Nursing, and they send out our survey with the license renewal. And this is what the survey looks like. Every 2 years when you renew, they ask you when you graduated, what degrees did you receive? And it pre-populates each year, so you don't have to re-enter the information that is older. So this slide shows you how many RNs there are in the United States. And do you see the totals up there? 5 to 6 million nurses in the United States. Then that includes registered nurses and practical nurses. So there's 5 to 6 million in the US. So how many nurses do you think there are in New Jersey? Any guesses?
I think that map said over 70,000.
Good guess.
100,000.
Yep, good observation. So it's greater than 75,000. And who said 100,000?
I just
Anyone else? All right, here are the numbers.
50,000.
Here are the numbers. Good guess, the 150. So we have, if you look at active and inactive of APNs, RNs, and LPNs, we have 225,000 plus nursing workforce in the state. And the largest workforce is the RN workforce. We still have a strong LPN workforce, and the APN workforce has been growing and growing each year. So remember that. Close to a 250,000 of nurses in New Jersey. That's how I try to remember it. Or almost 150 to 170,000 RNs. And then so this data is from when nurses renewed their license in 23 and 24. It's not mandatory, but we get a good response rate. 100 of the 177,000 RNs, 144,000 responded. The average age of nurses in New Jersey is 49, and the majority are female. And here's the race and ethnicity. And our workforce in New Jersey is similar to the national nursing workforce. And here's a slide on the diversity of the nursing workforce. And you can quickly see from this slide that the LPN workforce is much more diverse than the RN and the APN workforce. And the ages are pretty similar. We need you to enter the workforce, right? We need younger nurses entering the workforce. All right. There was a recommendation that 80% of nurses throughout the United States should have a BSN by 2020. So how are we doing on that recommendation? Did we
We're closer to half.
You say 50% of nurses in New Jersey have a BSN? Is that what
The
you-
other slide, it was 49%, and then 51 was associate.
Right, that's graduates. That's of the.
Oh, that's like
graduated-
new graduates, so the number is going to be even lower.
Well, it depends if you're optimist or pessimist, right? So what do you think? Is it
If this number is including nurses that had their degree, that got their license much earlier, then the numbers are probably lower because more people now are getting their bachelor's.
This number is of all the 144,000 RNs who responded to this survey in New Jersey. So they could have graduated in, we have some nurses who are in their 90s. They could have graduated in the 50s to present. So you're saying less than 50%. Anybody saying anything else? Is that correct? That's what you're saying, less than 50%?
I'd say more.
Give me a number.
55%.
Anyone else? All right, drum roll, here it is. 72%. We were supposed to, all states in the country, be at 80%, but we're slowly getting there. It used to be in the 60s. And with your graduation, you're helping us, right? Because you all have your BSN. All right, we have a lot of options of different places where RNs can work in New Jersey. Where do you think the primary employment setting is?
Hospital?
Yep, you're right. That hasn't changed. 55% of RNs in New Jersey are employed in the hospital. And you see all the different places where you can work. Home health, correctional facilities, insurance companies, hospice, occupational health. We also gathered data with the help of Lightcast to look at the demand for nurses in New Jersey. And we have a moderate demand. We're placed 19th highest in the US. The highest demand for nurses you see are listed here. And then the states with the lowest demand. So I think we're probably in the top 10 of demand for nurses. So that's very good for you. And what counties do you think have the most RN job opportunities? What county is your school in?
Ocean.
You think that has a high demand or more job opportunities?
I think depending on where there's more hospitals or older people, then there's a higher demand of nurses that they need.
And so how is your county then? You have a lot of hospitals?
Yeah.
All right, let's see. Yep, look at that. Ocean, Salem, Camden, Essex, and Passaic have the highest demand concentration. And Essex, Morris, and Bergen had the greatest number of unique job opportunities. That's information that we look at. And what positions are in highest demand? And I have the top ones listed here: nurse manager, nursing supervisor, med surg nurse, ICU nurse, ER nurse. You have no trouble getting a job, right? And here's another interesting slide. We were able to calculate the average salary and turnover for RNs and LPNs and advanced practice nurses, and you see that listed here. I know it's a lot of data I'm sharing with you, but I think I just want to give you a glimpse of what's available through the work of the New Jersey Collaborating Center. And we also do, based on this data, then we also look at other issues that are significant or impacting the nursing workforce. We've established a statewide nurse residency program. Hackensack Meridian has a very robust program. They're not a part of the statewide residency program, which is particularly good for organizations who don't have an established residency program. More LPNs are entering the acute care setting, so we're doing a research study looking at the outcomes of that integration of LPNs. And then we've recently collected CNA data. I think this is just a piece of trivia for you. The certified nursing assistants are under the Department of Health, whereas the New Jersey Board of Nursing has RNs, LPNs, APNs, and home health aides.
I have a question for you.
But not CNAs. Go ahead.
It's interesting that you're saying that LPNs are entering the acute care setting. I thought we were going away from it. Like the last 20 years or more, we were trying to go away from the LPNs being in acute care setting, and then now we're bringing them back in.
Yep, we're bringing them back in. Very good question. How did you know about that? That's very good. You're exactly right. It was like 20 years ago because of research that showed the impact that RNs make in patient care outcomes. But because of the nursing shortages, many organizations are bringing LPNs back into the acute care setting, and instead of having primary nursing model, a team nursing model. And the number of LPNs coming back, we know one hospital has 50, 60 LPNs in a community hospital.
Are they coming in a different scope of practice though?
No, the LPN scope of practice.
Yeah, meaning that not the way they were 20 years ago though.
There's no different. They
No
have
difference, but they're bringing them back to the hospital.
Yep.
Got it.
But very good question. So that's what our research is important to look at. How are the outcomes? What's the difference? Some leaders are saying that it's helping decrease the workload of the RNs. And there's more nursing on the floor, more nursing staff on the floor. We'll see, right?
I'm just curious if it's actually gonna decrease the workload, because I don't remember, we had a professor saying that they can't do certain things. So even if they get a patient, what's it called? They're taking 5 of your patients, but you have to still do all of the assessments on them. So then you're doing double the workload, really.
Yep.
And you can't do that, the initial one. So then they have to, so we have to do, let's say I have 5 patients and they get 5 other patients, I still have to go do all the assessments on their patients. So it's really double the workload, not decreasing.
Yeah, it depends on how the model's designed at each institution. Some, every institution's doing it a little different. But I will tell you, a lot of them have the charge nurse. Because the charge nurse ending up taking patients, they partner the LPN with the charge nurse. So the charge nurse does the assessments on typically a smaller number of patients that the LPN's covering. I'm not saying, I'm just reporting what I'm not saying I'm pro or con, I'm just reporting what we know about the integration of LPNs.
Got it.
But we'll see. It's interesting to see how it's going to work out. But
I think it would be more of a team model, right? Where they wouldn't get a full patient load so that the nurse, the RN would need to be taking care of the double load. It would be more of a team approach. So in certain areas it's working out, but I agree with Dr. Weaver that we need to watch the outcomes. We need to see, and we also need to make sure that our nurses are educated and understand how they can delegate and what they can delegate to the LPN.
Exactly. And the Board of Nursing in New Jersey is very clear. They cannot do, like, we did a research study regarding LPNs in long-term care, and the directors in long-term care were defining assessment differently. They were saying they were doing body checks, not assessments. And they said that they can do assessments, but they just can't do the admission assessment. And the Board of Nursing is very clear. It says it in the RN scope of practice that RN shall not delegate assessment. So we'll see. We'll see. And I wanted to share with this at the Collaboration Center. We also have a great podcast. There's this QR code that you can scan there to access our podcast, especially if any of you are going to be working night shift. We have some good podcasts with Dr. Carol Ash on night shifts and getting good sleep. And another QR code, if you want to receive the newsletter from the Collaborating Center, just use the QR code and sign up for our newsletter. And we have a lot of other data on our website. So it's all free for nurses in New Jersey. Now, I just want to briefly talk about professional organizations, particularly New Jersey State Nurses Association, which represents registered nurses in New Jersey and is a constituent member of the American Nurses Association. And really, NJSNA mission is to advocate and promote the profession of nursing. That's essentially it. They're here to be our voice of nurses in New Jersey. Part of New Jersey State Nurses Association, we have an Institute for Nursing, which offers scholarships and education programs. And so watch their website if you continue your education and would like a scholarship. Watch the website for the applications. And they also have the RAMP program, which is our Recovering and Monitoring program. And typically when I present to GCU students, you usually say, you've heard of this program, you've had a presentation on this? Correct?
We learned about it in our classes in nursing, like in our lecture classes.
Good.
I'm forgetting exactly which one. I feel like we first heard about it in med-surg, but.
Good. Yeah. It's a really good program that helps take care of nurses who have an issue with substance abuse. Very good program. We also in the American Nurses Association has something called Healthy Nurse, Healthy Nation. If you just put that into, if you just Google HNHN, it'll come up. You can participate in Healthy Nurse, Healthy Nation. Anyone can. And this originated because ANA recognized that nurses aren't doing very well taking care of themselves, not eating right, a lot of stress, overweight, and drowsy driving. So the rationale is if we take care of nurses, that will improve the health of our nation, of everyone in our nation. So, here's the website, HNHN. And we established in New Jersey, Healthy Nurse, Healthy New Jersey. And we have webinars and different programs. We had a walk 2 years ago. We're going to have a walk again this year. And I think they're great programs. I like both of them, but Healthy Nurse, Healthy Nation gives me text reminders. They have different themes every month. So this theme this year might be hydration this month. So they'll send me texts. Did you drink? Make sure you drink another glass of water or that sort of thing. Things we know. And I know you need this as students, with all the stress that you're involved in, especially with graduation and the NCLEX. So Google HNHN. Do something. Take care of yourself, right? And then these are different things that are sent out through New Jersey Healthy Nurse, Healthy Nation. Stop and take a breath. Take a walk outside. So I'd like to spend a few minutes to talk about New Jersey legislation and the Congress on Policy and Practice, which I've been a member of the Congress for many years, and I enjoy learning about the different legislation that is in New Jersey. So did you know that New Jersey is part of the Multi-State Licensure Compact? All I see is your...
Professor Egan just spoke about it in class last week.
Oh, that's great. What's your first name? You seem to know a lot about the nursing profession.
Nechama.
Oh, very nice. You're very knowledgeable. That's good. Well, just to give you a little history of how long it takes us to get bills passed. It first was passed in, more than 20 years ago. But after a bill is passed, you have to write the guidelines for the implementation of the bill. And the law expired without being enacted. And then you see the last bullet. This legislation was introduced because every 2 years you have to reintroduce any bills that weren't passed. So we kept reintroducing it. And the licensure compact is run through the National Council of State Boards of Nursing. And in 2017, 2018, a lot of their, the compact guidelines had changed and were updated. So that really helped us to get it passed. So it passed, the law passed in July of 2019. And then COVID happened. And we had partial implementation during COVID, which meant if nurses were part of a compact in another state, they could come and work in New Jersey. But those of us in New Jersey who wanted to join the compact, we couldn't join until November of 2021. And this is the current percentage of nurses who are either single state or multi-state. And right now, 10% of the nurses in New Jersey are multi-state. So when you sign up for, go for your NCLEX and license, think about whether you want to be single state or multi-state. When we could join the multi-state, because I also had a Pennsylvania license, I transferred and now have a multi-state license. So, and this is an interesting slide, right? These are all the states who are part of the compact in the Navy. Pennsylvania has partial implementation, and you see the states in light blue who have are awaiting implementation. So a lot of states are participating in the compact. Isn't that interesting? This is another bill I want to talk to you about. look at this slide. Lot of states, 39, protect the title nurse, not New Jersey. We've had bills in the legislature since before COVID to protect the title nurse, which means only RNs, LPNs, APNs can use the title nurse. And this came to the attention of nurses at New Jersey State Nurses Association, because you know who's using the title nurse? Particularly vet techs are calling themselves nurses. And then think when you go to a medical office, when somebody takes you back to the room, are they saying a nurse? I always ask, oh, where did you go to school?
But people automatically assume anybody in scrubs is a nurse. It's not that meaning if you're a medical assistant, if you're a tech, they automatically think anybody in scrubs is a nurse. It's not that that a PCP is gonna say she's a nurse or a medical assistant will say she's a nurse. People just assume that.
But these vet techs are calling themselves nurses. They're not, they're calling themselves nurses. So this is to protect this. And I was very disappointed we couldn't get this passed in the legislature during COVID even. We couldn't get it passed when we were heroes. But I think the issue is if the 225,000 RNs, LPNs, and APNs in New Jersey reached out to their legislators and said, this is important. Pass this bill. Protect our license. We've worked hard for it. We don't want other people using the title nurse. So think about that. Would you agree? You've worked hard for your future RN, right? Silence. You agree or no? And there's financial penalty when this bill would pass. There's financial penalties if you're using that bill.
It makes sense because to differentiate other people like might not know, and like it is like a safety thing. Like the amount of training we have, we did work very hard. Like we have to work so hard on like knowing nuances, and like really all of it is like the better trained you are, like the less mistakes you're going to make. Like if it's our loved one, we would want someone that has a license, and like if someone just said nurse, like the patients wouldn't know the difference, and it's like it's not really fair to them.
Yeah, that's a very good point. So write that up and send it to your legislature. You're a voter in your county, and they want to hear from you. That's an excellent point. It can be very misleading to somebody trusting this alleged nurse's recommendation. Like to share some, in addition to the compact that finally passed, this legislation passed rather quickly, and we were one of the leading states in getting this passed. This requires healthcare facilities to adopt and implement policies to prevent exposure to surgical smoke. I don't know if you've been in the OR, but it's a very distinct odor when they use the cautery, and inhaling that is very detrimental to those in the OR. And the other interesting thing is many hospitals, I wouldn't say many, pretty much all hospitals in New Jersey have smoke evacuation systems. So why did we need this legislation? Because the doctors didn't want to use it. So this legislation required them to use it. It was passed and signed by Governor Murphy in 2002. And we're one of the 9 states that have passed this legislation. Isn't that interesting? Anybody expect to go to work in the operating room? Be safer for you now. So we're in the 221st legislation session now in New Jersey. And this is a bill we're really working on. And this is for advanced practice nurses. I don't know if you're aware, but currently advanced practice nurses must have a collaborating physician. Governor Murphy, during the pandemic, had an executive order that that they did not need the collaborating physician. And interestingly enough, we have had the outcomes have been good even without collaborating physicians. So we've had, this is the current bill here in the New Jersey Senate. It's sponsored by Senator Vitale. There's a QR code there if you want to click on that and send an email. It helps you, it's really simple to fill out, takes you maybe 2 minutes to give your opinion whether we should pass this bill or not. Look at all the co-sponsors. Do you know how many senators we have in the Senate? There are 40 in the New Jersey Senate. We have 24 primary and co-sponsors of this legislation. So if our Senate president puts this for vote in the Senate, it would pass. We're having problems getting it put up for vote. But Senator Vitale is a real advocate for nurses. If anybody's in his district, thank him in his sponsorship of the bill. And he informs us that he expects this to progress this legislative session. So fingers crossed. And look at all the other states where the green states are, where RNs have full practice authority. Maybe that's your future as an advanced practice nurse. Help support this legislation. And sometimes there's fun bills we can talk about, like RN license plates. There's bills sponsored for that. And then, of course, we have a staffing legislation bills. Different types of staffing legislation bills. They've been in the Senate and the Assembly probably since 2002. So here's another QR code that helps you go right to contact your senator or your assemblyman. It's so easy. You just send an email, put your email address, just click on that, just scan that QR code. And then when you scan the QR code, it takes you to this and you see the information that you would fill out to contact your legislature. So easy. Use your voice. As a future nurse, you have a voice. You're not, I would even say as a graduating senior from a BSN program, or you can even put Georgian Court. And if you're interested in learning about more legislation in New Jersey, at the Collaborating Center, we have a page which lists all the top bills related to nursing. And then if you click on it, it will actually pull up the draft of the actual bill. So you just go to NJCCN website. And so I just want to conclude by really advocating that you join a professional organization. Believe it or not, soon you're going to be out there practicing as nurses, and there's going to be no faculty saying to you, you should read this article, you should read this. Did you hear about this information? That's what your professional organizations will do for you. As past president of the Infusion Nurses Society, I like to advocate for them. Each specialty organization focuses on a different specialty practice. And I was always grateful to infusion nurses throughout my career for their standards of practice, which is all evidence-based on what we should be doing. Like when I started my career, we changed IV sites every 72 hours. That has changed. There is no deadline for that now. as long as we're doing frequent assessments. Right? So joining a professional organization is really important. And I have all these screenshots of different organizations, like the Emergency Nurses Association. And before you join, think about what does joining offer you? You know, typically it's a journal, reduced price at their conference, access to their website with a lot of evidence-based information. ENA, I remember they were advocates of, they started the initiative for family presence during a code. Really important. Not everybody wants to be present when their loved one is coding, but it really helps some people. And then the American Association of Critical Care Nurses. They established the standards for healthy work environment. The 6 standards, one of which is staffing, but also good communication, authentic leadership, meaningful recognition. All are important. You could have great staffing, but if you never see your nurse leader, except when you've done something wrong, you know, that doesn't make for a healthy work environment, right? And the perioperative nurses, AORN, they were very big advocates in that smoke evacuation legislation. And then, of course, NJSNA, which is advocating for you right here in New Jersey. So I'll stop sharing and open it up to questions. Silent group.
Is there an organization you would recommend as the absolute most important that we join as graduating students?
Well, when I graduated, I joined I worked at Hershey Medical Center, and I joined Pennsylvania Nurses Association because I was on a med-surg floor. I didn't really know so I would recommend that. And I've always been a member of NJSNA, and I feel like it really opens my eyes because you get so focused working in your hospital on your unit. I love that it opened my eyes to what else was going on in nursing. So that's what I would recommend. The State Nurses Association, wherever you work, start with them. And I think the price is really reasonable at NJSNA. Other questions?
Thank you.
Sure. Any other questions or?
Yeah, I have a question.
Yes,
Earlier you were talking about when we would like sign up for our licenses, register for our licenses, like you would can decide if you would want to sign up for a single state or a multi-state. Why would someone not want to be part of the multi-state one? Isn't it just like worth it just to get that one?
Yeah, that's my opinion. You never know what the future holds. So yeah, right. Just sign up for the multi-state.
Okay, thank you.
That's, yeah.
So are they changing it now too, that you automatically sign up? I thought that's what they said at New Jersey Collaborating Center the last meeting.
Oh, I wasn't aware of that. Really?
I have to check on that. I think that's what they said, but I'll check on that.
Okay. Yeah, I missed that meeting, so I don't know. But yeah,
Any other question? Go ahead. I'm sorry.
no, that's okay.
Any other questions for Dr. Weaver?
I just want to add regarding the legislation, we do present to the Nursing Congress at Hackensack Meridian Health. And I think in your career, it's important that you really try to stay knowledgeable about the current legislation that's going to impact your practice. Because who's in the Senate and Assembly in New Jersey? They're primarily businessmen. We have one nurse, Nancy Munoz. And I know the first time I talked to my senator, he was grateful because you can explain to him your world of nursing. And that's what they want to hear. And so we're grateful at HMH that we're sharing with all the nurses about legislation that impacts your license. And just think if we were all more involved or knew how to relate had at least communicated with our senator or assemblyman, we could really make an impact in New Jersey.
We are the largest health care profession in New Jersey, right? Our numbers are great, so we do have power.
If we would only use it.
Right.
We recently had an assignment actually for this, for our leadership class, that you had to like respond to, like, let's say like an act that was passed and say if you agree or not. And I actually didn't agree to what they were saying because like it wasn't the right, I didn't feel like it was the right action to address the issue.
Good. That's great. Who taught that class?
I have Professor Yatushak.
Very good. That's good. Yeah. And then we're also, you know, I tend to be biased looking at nursing legislation, but we're also looking at other legislation that impacts the health of those in New Jersey. Like they want to eliminate all smoking in casinos, you know, but there's some resistance to that. There's still smoking in those designated rooms in casinos. They want to eliminate all that. And so we as nurses, we should be advocating for that. Yes, that's the right thing to do. And there's another bill in the legislature that all, not just, I think it's under 16, wear bike helmets when riding a bike. Everyone should be wearing a helmet when riding a bike. So we're trying to advocate for that also, not just the nursing bills.
Yeah, because we're patient advocates first, right? To be looking at the health of all of our citizens. Okay, anything else for Dr. Weaver? Thank you very much. I know how busy you are. Thank you so much, Dr. Weaver, for coming in today.
Sure. Best wishes in your career. Thank you for having me.
Take care. Okay.
Thank you.
I believe that our last speaker is here, and that would be Amanda Lillis. Amanda, are you here?
Hi, Dr. Wormser. I am here, and I'm here with Chrissy Gustafson. She's our coordinator for Hospital from Home. Many of you, if you've come to experience Hospital from Home, may have met Chrissy or myself. So we are here to talk to you about Hospital from Home.
Thank you so much, Amanda, for making yourself available, and Christine. And if you need to, you can share your screen, or if you just would like to talk, the floor is yours.
I will share our screen and talk to you all about Hospital from Home. So this is something that has been fairly newer to Jersey Shore and to HMH. It was very interesting that I caught the tail end of Dr. Weaver's discussion about legislation, because this actually has gone through legislation. So pretty interesting how those two can connect and segue. Anyway, so Hospital from Home is a virtual care model. It's basically like a hybrid model that allows us to take our patients that are admitted and hospitalized and bring them to their own home and allow them to receive care in their home. This started in 2022 for Jersey Shore, but actually it started prior in other facilities across the country. But we adopted this model as a pilot program in July of 2022 because this was a Medicare waiver that had gone through during COVID to allow a little bit more room in the hospitals and take those patients that weren't as acute as the COVID patients that were needing the beds in the hospital and bringing them to their home and allowing them care there. So our chief nursing officer had heard about this and decided that she wanted to apply for the waiver for Jersey Shore and start this program here. So JFK, which is one of our sister facilities, actually started the program a few months before we did. Then Jersey Shore onboarded in July of 2022, and HUMC came after that. So it is a hospital substitution program, as I said, for patients that have medical conditions that require hospitalization. So they have to meet the inpatient status. They can't be observation, they can't be same-day patients, but they have to be inpatient. They have to meet certain clinical stability, certain criteria in their home to make sure it's a safe environment for them and for our nurses, and then allow us to be able to bring that virtual model to them. We have provided care to, very happy to say, 238 patients since April of last year. So in less than 1 year, we've had 238 patients that we have serviced safely on Hospital from Home. And prior to that, we had 67 patients in our pilot. So we have really seen such a transition and a change to be able to increase our services to patients and bring them to their home. We know they recover better in their home. That environment is, the best environment. They get better sleep. They are in the comfort of their own home with their own animals and family and friends able to visit them, etc. We provide them equipment, and it's pretty interesting and cool. And if you asked me a couple of years ago if I ever thought that I'd be doing this, I did not. It just kind of came our way. So Chrissy was working with us in the float pool. And she was one of the nurses that would go into the home and care for the patients, and really took a big interest in this model and saw the benefits of it, and really became dedicated and said, I want to grow with this. And Chrissy came on as our coordinator in August of 2023. Right? Yeah. So where she helps to identify the patients that are appropriate for the program, talk to them about it while they're here in the hospital, and then help transition them into the home. We take patients directly from the ER. Once the ER physician decides that they can be admitted, that they're going to be admitted, the ER physicians will often reach to us, but we also use the technology of Epic to help us find those patients and sort them, because there is criteria that we'll get into in just a minute. And then we also take the patients off of the regular medical surgical units or the tele units and bring them into their home also. So it could be either way. And when the hospital looks at it, we call that either a hospital substitution, where we save them from hitting a bed completely if they came right out of the ER, or if they're considered a reduced length of stay for the hospital beds from the units. And these are things that as you progress in your nursing career, you'll hear, but you might be saying, what is she talking about, a reduced length of stay or a hospital substitution? But it's good for you to start to hear those things. And then as you continue to start your journey of working in the hospital, or in different settings, you'll be able to understand that. This is a slide that shows you what we can do. So the hospital, we now call it Hospital from Home, and I couldn't change the slide, I apologize. The Hospital from Home program allows patients almost all of the things that they would have in the hospital in their home. There are some diagnostics that they would have to come back to the hospital for, such as an MRI. We don't have a mobile MRI machine to go to their home, so they would have to come back to the facility for that. But almost everything else gets delivered and brought right to them in the beauty of their own home. So we have portable chest x-rays that can go out to the house. We have ultrasound that can be done in the home. Phlebotomy, our nurses go to the house and they draw the labs, but there's also a company that can help back us up for that. We have a social worker that does visits virtually with the patients and calls to make sure that they have everything that they need for when they're being discharged, just as if they were in the hospital. We have that team working for them. It's the same situation with the social worker in Hospital from Home. We have the ability of providing physical therapy in the home, speech therapy, occupational therapy. Typically, we like to identify the need in the brick and mortar. And when I say brick and mortar, I mean the hospital walls. And if we know that they need a physical therapist as part of Chrissy's communication and intake and transition to the home setting, she'll say physical therapy recommends continued therapy while in the hospital. So they'll have a therapist go to the home. We have the ability to offer home health aides. They have the option of having a live-in, where they would have to provide a separate room for them to stay in, or an hourly aid, as we call it. So like for 3 to 4 hours at a time if the patient needs it. We have protocols that we follow that are hospital policies, and that's what drives our care in the home. We have home technology. So we provide the patient an iPad that has a button that says talk to my team, so they can call their nurse at any time. It's like their call bell in the hospital. And a nurse will pop up on the screen in a virtual setting, just like I am for you guys today. We have a blood pressure cuff that gets provided to them. When they do their blood pressure, it actually says your blood pressure has been recorded and is 135/70. so the patient can hear it and it reinforces that value. Just as if you were the tech on the floor, the nurse on the floor, you're going to do the blood pressure and you're going to tell the patient what it is. The technology will tell them that as well, especially if the nurse isn't in the home at that time and the virtual nurse says, I need you to recheck your blood pressure. Let's put the cuff on and then obtain that value. We provide them an emergency response button. So, the commercials that you may see, I've fallen and I can't get up, we provide them a button like that. They can wear it either as a necklace or they can wear it as a watch, so that if something were to happen, they have instant communication instead of having to go back to that tablet, and they can get the help that they need. We can provide oxygen in the home. We can provide nebulizers. We provide them a backup battery so that in the event of a loss of power, the equipment that we are supplying them in the home would have some battery backup and give us enough time to transition them back to the hospital if necessary. So if it's a long anticipated power outage, it gives us a little time to coordinate their transition back to the hospital. Skilled nurses, we provide for Jersey Shore our own nurses. So Jersey Shore nurses that were trained here were hired into our department last year. That was all new for us, so we built our team. So those of you that had the ability to go out into the homes, those were our nurses that you were with. And other facilities do use agency nurses, but again, they're also put through expectations of HMH as well. But we're very proud of our nurses at Jersey Shore. We know their skills and their capability and their connection, and they really have found such a love for this program because they get one-on-one time with the patients. In the hospital, you're in a patient's room, your phone's ringing or a call bell's going off for somewhere else. For them, they're really focused and they get one-on-one time, and you get to see how the patient is functioning in their own home. You get to know them a little bit more on a personal level, which is fantastic. We have paramedicine, as it says here, triage, IV access, labs, EKG, fluids, antibiotics. That's actually what our nurses do. EKGs will be done by an outside company. They'll come to the home and they'll do the EKG, but we do have the capability of doing that. Our paramedic team helps us with transports. So our BLS can bring the patient from the hospital to their home if the patient requires oxygen and transportation. And then if the patient needs to come back for something that's scheduled, they'll also bring them back to the hospital for that testing. Dietitian. We provide dietitians because we know that, healthy nutrition is an essential part of healing. So we want to make sure if they were in need of a dietitian and follow up in the hospital, that we offer that in the home. And those would do a virtual call with the patient as well. They don't always go to the home, but it's a virtual call to assess them and have a discussion.
Same thing with the diabetes educator.
Yep.
So diabetes educators, we had somebody who wasn't really used to insulin and actual insulin injections and how to administer them. So we ended up setting up a virtual call with this particular patient and, taught the patient how to do it. We had the nurse in the home while that Zoom meeting was going on. And step by step, they went through everything about diabetes and how to inject the insulin, which was a very nice thing to do. We didn't have to bring him back to the hospital to do that and then send him back home again.
Yep. I'm trying to think what else. DME supplies. So as Chrissy said, when we have diabetics, we provide them a glucometer in their home to be able to check their blood sugar when we are not there. So sometimes you have patients that need blood glucose monitoring because of their steroids or Solumedrol. Or some that are maybe, diabetics, but they're diet controlled and they still check their sugar. We would bring that equipment to their home. We provide a very large supply box. So hopefully most of the supplies that our team would need would be already in the home. Our nurses do carry bags and they do have items in the bags that they would need. But the general supplies, such as some wound care supplies, gowns, IV, angiocaths, tubing, flushes, etc., are delivered upon admission and daily if needed by our supply company. They will supply the nebulizer, they'll supply the tubing, They can supply a concentrator. We generally will take patients with less than 6 liters of oxygen. When you get to greater needs of oxygen at 6 liters, they're a little bit more acute and really safely treated in the hospital, probably better in their home. So if there was any kind of decompensation, they would actually be in the brick and mortar. But generally, we say up to 6 liters is our max to be able to take them to the hospital from home program. And then we do infusion. We do not do continuous infusion or like TPN overnight, not yet anyway. Again, it's a fairly new program, so we're doing, I'll say, a slow rollout when it comes to certain things. But we do have the option of giving boluses in the home and again, IV antibiotics. And I know that's a lot. I'm not sure if you guys have questions yet or thoughts. If you do, feel free to go ahead. And if not, we'll just keep going.
When you say no continuous infusions, I'm assuming that means like not including like LR or normal saline or whatever, right?
Right. So when I say continuous infusions, we can do a bolus. So like over an hour, if the doctor said, patient's CHF maybe go over 2 hours, we can do that. But we can't do like a, 75 cc an hour for 24 hours. Generally we'll find that we do have patients that have AKI and maybe are treated with fluids and nephrology is on board. If nephrology is in agreement that the patient can get twice a day boluses of the fluid that they were needing, we can absolutely accommodate that. And we have nephrologists that have happily joined us in terms of doing virtual consultations. So if your patients have multiple specialists on their case, such as infectious disease, pulmonary, nephrology, they can actually do virtual consults. So those patients can be seen every day via video tablet, which is
they
amazing.
also upload photos. So like you have somebody that comes in with cellulitis and, the infectious disease doctor wants to see how it's improving, maybe switch up the antibiotic if it isn't improving, et cetera, like that. But they upload pictures every single day so you can see the day to day how it's improving or not.
Thanks.
You're welcome. Great question.
I was also just curious, is this something that new grads could do or they can't really do it?
So I would say that we take more of experienced nurses into this program, just because you have to develop your assessment skills and you are the eyes of everyone. So when I say that, you're the one that's in the home with the nurse, with the patient as the nurse. So your assessment skills are the eyes of the doctor. The doctor sees the patient daily via video chat and tablet. And generally they'll do it when the nurse is in the home. But something that you want to really focus in on is your assessment skills, because you're going to advocate for what the patient needs. So when I was a new grad, I started out as a night nurse, and that was something that I absolutely loved. I did it for 18 years. And it was before we had hospitalists at Jersey Shore. It was when we had a lot of private attendings. And I knew that if I was calling a doc at 2 o'clock in the morning, I really better know my assessment really well and know what to call the various things so that I could help get the patient treated the right way, because that doc wasn't necessarily in the building. And I feel like it's very similar with hospital from home, that the nurses have to have really sharp assessment skills and communication skills to be able to relay what is needed for the patient. Not to say that the doctors can't, they absolutely can. And the virtual platform allows the doc to see them and is very clear. But I think the advocacy part for the nurses that are in the home is really critical. So generally they have to have about 2 years experience, but always something as a new grad to keep in your head to think about, because even let's say you're working at one of the hospitals that has the program, you're one of the people that's going to help us find the patients that are appropriate. You refer. We get a lot of referrals from the nurses that say, hey, is this patient eligible for hospital from home? I think that they would do really well. And we can look and say, do they meet all the qualifications? Like, we take that off of your plate. As if you say, hey, I think this is a candidate, we take it off your plate and say, let's check the mileage and see if they're within 25 miles of the hospital, which I'll get to in a few minutes. Does their insurance participate? Because we don't want a patient to be brought to the home and then all of a sudden get a bill for the services, because some insurances won't cover hospital from home, even though it's an inpatient program. So there's a lot of variations and things that go into it. But as a new nurse, I always think that you want to keep your eyes open. to different things and understand the various parts that can be a part of patient care. And that would, that's something that you can make a difference. Knowing how your patient might benefit from being home and identifying that and seeing if you can play a part in that is huge.
Got it. Thank you.
Oh, you're welcome.
I also just wanted to add with like your skills as a nurse and everything over those 2 years, your blood work and your IV skills, because you're the only one in that home. So if you can't get them for blood work or an IV, somebody else has to go out. You don't have somebody right in the hospital to be like, hey, can you help me try to get an IV on somebody? It's just you in that home.
It's a great point.
Yeah.
And I apologize because I'm presenting. I don't see if there's any other hands up. So if there are, just come off mute. I'm trying to look through. Okay. So the whole goal and purpose of developing the Hospital from Home program was really to start to use an innovative model that was also cost effective and helping patient outcomes, right? So it's multifaceted. Reducing overall cost of care. So upfront, starting this program actually has a really high cost. But the benefits are for the patient, right? It reduces a cost if they don't need a rehab stay, for the patient. It's allowing us to decrease a little bit of volume in the hospital and allow that bed to be backfilled. Go ahead.
They're actually being billed like as if they're a patient in the hospital though, right?
They are. And they're receiving the same services, just not within the walls of the hospital.
So that should actually cost the hospital less in essence.
In essence.
But all the supplies and everything and the people back and forth ends up adding up.
It does. And so you don't realize the cost of transport then gets brought into our program costs. So the patient isn't being charged for that ambulance ride, but the hospital is paying for it. So, again, up front, there are incurred costs that are a little bit more for us to run the program. But again, the benefit to the patient is there and it shows its value. And overall, it'll allow us to backfill that bed. So essentially, you're putting a patient in a bed behind it. Right.
Mm-hmm. Got it. Thank you.
Oh, you're welcome. That was a great question and great thinking. And I'm sure in the next few years, once insurance is, who knows, they may turn around and reduce what the overall payment is if you go on Hospital from Home, just like an observation status is a set payment. It could be something like that, but we'll cross that bridge when we get to it. Improve patient experience. That is a huge thing for our patients, right? So I'm sure many of you have seen various hospitals during your school, and you've seen probably days that the volume is extremely high where people are lined up in hallways and, it almost looks like it's, a war zone, right? Like you're just seeing a lot of patients everywhere. And that decreases satisfaction because a patient comes here and doesn't feel well, and to sit in a stretcher for 48 hours in a hallway, it's not comfortable. So it allows us to be able to move them to their home, let them get sleep in their own bed, again, be with their family, etc.
Shower. They love taking showers in their own shower. And then also when you think about it, somebody that's in a hospital bed, you're confined to that one bed. Let's say you're on isolation or something. At home, your whole house could be isolation.
Right.
But when you're in the hospital, your only little room that you can walk about, a lot of people lose their muscle mass over a couple of days of being in the hospital. But then when they're at home, they're up and walking as they normally would be, and they keep their strength.
Yep. And then we have, yeah.
So at the beginning, I heard like the numbers a little bit that in less than a year, 238 patients were serviced safely. I was just curious, the word safely struck me. Were there patients that things went wrong? Do you have numbers on that?
I don't have numbers on, I can get numbers. We monitor our escalations, right? So, and safely means that even if they needed to come back to the hospital, we got them back to the hospital. And you use the word safely because people view the hospital as a safe place, right? They want to come in and receive care. They feel comfortable there. So to say that word safely, maybe I overused it for the home, but basically showing you that it is approved and it is a way that you can still get that hospital care in the home. Escalations are expected. So there are patients that you can expect might come back, whether it's for additional follow-up. A consultant says, you know what, I've managed them via video 2 days. I really need my eyes on them and like physically need to see them. We bring them back. We've had patients that, we've done a CAT scan. We say, come back, we'll do the CAT scan. We send them back to their home. They review the CAT scan and the doctor, either the virtual doctor or, one of the consultants says, I want to bring them back. They come back to the hospital. We give them a bed. So that's when I say those words safely. Their care is delivered in the safest way possible and their needs are met, whether it's they need to come back or they get discharged.
Thank you. That's like a lot clearer to understand. I was like, is there a different number of people that got services and something? So this made it clear, like what that is. Also, like I didn't realize that if a person has to go back to the hospital, but like it was done safely, that's also included. Like that's very interesting. Like
Yes. We've had patients before, like Amanda said, where the doctor wanted to see and put eyes on the patient, and that happened. The family brought the patient, eyes were put on the patient, they did their note, they did their assessment, and then the patient went right back home. Like there wasn't a need for him to stay in the hospital any longer. So he was still in service with us. And then there's also been a time where on a Friday, there's a patient that's going for a procedure that's not going to happen until Monday because they're closed on the weekends. And we put them in their home for the 2 days, 2 to 2.5 days. And then they come back on Monday, have their procedure, and they went back to the program right back home. So those are just some instances that happened as well.
I will share a story with you that we're actually, it's a crazy story. It's a proud story. And it's been advertised for any of you that are in HMH. It's been on the Pulse and the One and all that stuff. So we did have a patient that was transitioned to his home. He was being treated, was a UTI, I think, right? Yeah. UTI. And he was in his house for a day. The nurse went the next day and did lab, or 2 days he was in the house, did lab work. And all of a sudden we got a critical result. So remember, the labs were done in the home by the nurse. They get brought back to Jersey Shore. They get processed. So the day prior, his potassium was, I think, like 4.5. It was within normal range. The next day, we get a critical result after the nurse had sent the blood back, and it was like 6.1, and had no history of AKI or renal insufficiencies or anything. So the virtual provider and the virtual nurse talked to the patient and said, you need to go back to the hospital. We need to treat that potassium. We need to monitor you on telemetry, which we cannot do in our program. So the safest place for you is in the hospital. And the patient said, no, I'm not going back. And typically if that happens, then we say, okay, then, you're basically refusing our care and treatment plan. Is this going to be considered an AMA? And you have to have a really good discussion with that patient before you go that route. And Chrissy was here and she said, are you seeing what medications they're trying to give? And that's how we all got involved and said, we can't do that in the home. He needs to come back. And again, patient continued to refuse. So instead of going the route of, okay, you're refusing our treatment, can we send one of our nurses out there, have that in-person conversation, maybe redraw the labs and see, is this a hemolyzed situation where we got an abnormal value? Because how did it jump so much in a less than 24-hour period? So the nurse was going to the home and she was orienting a brand new nurse who had just started that day with us, but was a former CVICU nurse and worked in cardiac rehab. We carry AEDs as part of our equipment. And then 2 nurses went into the home, spoke with the patient. Again, as soon as they walk in, I'm not going back, he says. And they said, well, we're here to do your blood work and let's talk about it. So they obtained his labs. And the one nurse was showing to the new nurse how to label it, what we have to do to make sure we're identifying, because we don't have the scanning capabilities that the hospital does. And out of the corner of her eye, the nurse that had been with us for a while looks over and sees that this patient has a blank stare and started shaking, almost like a seizure. So she immediately went over. He did not have a pulse. They hit the emergency button on his watch. They hit the command center tablet to get the virtual nurses on and activate 911, lowered him to the ground, immediately started CPR while the other nurse applied the AED. It advised a shock. A shock was delivered. CPR continued for another minute and a half to the patient waking up, again insisting that he was not going back to the hospital. He did go back to the hospital.
He's very stubborn. He was a stubborn man, but very nice.
And he wound up needing a multi-step PCI and really was recommended to have open heart surgery, but was not a candidate. So he was pretty sick. But when he came back to the hospital, we all visited him and he thanked us all and really just was, it was an incredible, amazing story. And the nurses need to go and like ready to jump, and the AED that we bring anyway, and the new nurse on orientation, it was all there. But it goes to show you that we have things in place to make sure that we provide that safe care. So going back to that safe care, that's where that is. And, you know, we didn't just look at it as, okay, he's not compliant. Let's get to the root of what's happening. Let's have that conversation in person with him. And they saved his life. And his grandchild, I think it was his grandson, and his family walked in
after it all happened, and as the ambulance was just arriving.
And they just said, you know, you saved his life, and thank you. We can't thank you enough. And, you know, looking at this patient, the risk factors really weren't there to indicate that this could happen, right? It could happen to anybody. I could be walking down the hallway and have an event. And it just so happened that we were all heavily involved to see what can we do to make sure that this guy gets what he needs. We know it was not safe to say this is an AMA. We knew that. We didn't want to go that route. So what can we do?
And we did initiate that visit.
What do you do in the event that like the nurse wasn't there then? Like she's not there 24/7. So like,
yep. So if the command, we have a command center that's 24/7. I don't think we even got to that point, but I'll explain that to you. So it's not just our nurses that are in the home. Our nurses go 2 to 3 times a day into the home, but there's a nurse 24/7 via the tablet. So the virtual command center nurse does check-ins throughout the day with the patient as well. Let's say they call a home and they can't get a patient. It's the same thing as if you're, not the exact same thing, but similar. If you're in the hospital and you go into a room and the patient's sleeping and you're trying to wake them up, if they can't get in touch with them, there's an escalation protocol that if they try to reach the patient, and there's no reaching the patient through multiple modalities, whether it's the telephone we provide in the house, their cell phone, or the tablet, they're activating 911 to do a wellness check on them.
okay.
Yep. So when I talk about the safe care, that was a safety story. And our team was really recognized for their amazing work because everybody worked together. The command center nurses activating, 911 and making sure that was taken care of, while the other one was watching during the CPR to make sure everything was being done there that needed to be done. It was a true team effort. And the physician was also on the call once the command center nurse calls the doctor, and the doctor jumps on the video as well to help to treat that patient until the EMS team gets there.
Thank you. That story was like, it shows us how it all works, like keeping the patient safe and everyone being a team.
Yeah, we have a lot of redundancies in place to make sure we're doing everything that we can, and a lot of eyes on it. So it is actually, to me, it's a lot of work to coordinate to do this for the patient, but the end result of the patient being happy, the patient who is immunocompromised being in their home versus, anyone having that risk of hospital-acquired infection, et cetera, it really is beneficial. And as Chrissy said, the risk of, deconditioning, when you sit in your bed in the hospital, I don't know about you guys, but if you sit at home and just decide that you're going to binge watch something on Netflix, you get sore and tired after a while, right? Yeah. So, it's the same thing as them sitting in the hospital room and not really doing what they could be while they're in their home. And that's actually going to help them thrive. This is just telling you how it all started, which I touched on before, the CMS waiver. And that was actually at legislation, right? So in the state of New Jersey, we had nurses from Jersey Shore, our chief nursing officer, a representative from Jersey Shore as well, went to the state house a couple of years ago and really advocated to have some changes and to push for hospital from home. So that talks about nurses being involved in the legislation part. And they did advocate to have more commercial payers participate in this program. So it started out with just Medicare, which really limited the amount of patients in the population that you could sign on to the program. And now it has been pushed to commercial payers to start participating. So we're seeing a larger amount of candidates now because the insurances are actively participating and accepting the program as a modality of admission to the hospital. This overall 782 since last year is for our network. So that's JFK, HUMC, and Jersey Shore combined. So in less than a year, we've serviced, over 780 patients, which is really crazy to think about how many beds that opened up within each of these hospitals for those patients. And we partnered with Medically Home, who has also helped Cleveland Clinic, Mayo Clinic, Kaiser Permanente run their programs as well. So Hospital from Home is not just here at HMH, it is throughout the country. 140 plus, I'm sure there's even more now at this point. And Mayo, and I think Virtua is also in New Jersey. They have a program as well. They do use Best Buy. And when I say Best Buy, yes, I mean like the company, the store. They do the technology piece for Virtua. Let's see. Our waiver is currently extended until September of 2025, and we're hoping that the next extension that happens in 2025 will be a 5-year extension. So we're really hoping that that's going to come through, and we do believe that it will pass. So they did just pass the extension in the middle of March for this program again, but HMH is fully invested into making sure that this works, and we're actually expanding to Ocean Medical Center and Southern Ocean Medical Center on June 3rd. So very exciting. So program inclusions. What types of patients do we take? We have patients that have CHF, we have COPD, pneumonia, flu, COVID, UTI, cellulitis, pyelonephritis. We've had patients with diverticulitis, shingles, etc. As you can see, various commercial insurance, Medicare, Medicaid, charity care. Again, that continues to grow. HMH just recently had come to terms of an agreement with Horizon. So they're still working out some of the Horizon participants for us to be able to take more patients onto the program. But currently, we have quite a variety of patients to choose from every day. Again, it continues to grow. When you look at our numbers of potential candidates versus how many we actually sign on, it's because the clinical acuity and, the things that are going on, it's not that easy just to find a patient and sign them on. You have to make sure that it's safe for them and that they're in agreement. It is a voluntary program, so the patient has to agree to doing this modality. We don't take tele patients, as I said, but we can do EKGs in the home. This is a video I'm going to share with you. Hopefully you'll be able to hear it. This is from our pilot program, and this shows you one of our patients along with one of our nurses from the hospital, and she talks about why she really loves working with Hospital from Home. So I'll show you this video real quick. Can you hear?
I heard the audio and now I don't.
You hear it?
No.
No audio?
I heard the music for a second and then I stopped hearing.
Same.
Okay. We're going to try again, and if not, then I'm going to show you a different one.
Don't hear it.
All right, so we're going to skip that one. I don't know why that happened.
I think I hear it now, but unless it's just the music again.
It was the music again. All right, let's see. Let's try this one. This is a new commercial that just went out for the entire network. This has been seen on the Food Network channel. Hold on. And various other channels, I want to say, maybe like the home channels, etc. So let's try this one, see if you can hear. Let me do a stop share, and let's do this one.
Here, also share system audio on the bottom over there.
Oh, there you go, Chrissy.
Thank you.
Quick.
I think you're muted now.
Yeah, and then just, now you're good. You can hear us now?
No. Okay. All right, now let's see. Let's try this next one. In that video, just something very simple. All it's showing you is how HMH is really just trying to transform care and bring the care to the home for the patients, which was really nice. This one is one of our nurses, Heather. You may have met Heather, you may not have, but Heather is been a nurse at Jersey Shore for over 10 years, I think.
Yeah.
So she was actually the nurse that had found that patient in that story I was telling you about, had drawn the labs, etc. Heather is really amazing, connected to the patients, but she's going to go over what to expect day one when you're in the house. It is very overwhelming to the patient. The day that we sign them on, they get multiple visits from us saying, okay, do you agree to this program? Then we have to ask a whole bunch of questions about their home environment. Do they have running water? Do they have toilets that are flushable? Do they have, a freezer for food if they need it? Do they have
A microwave to heat up any frozen meals that we would give them? We also ask, is your home safe for you and others? Do you have any firearms or weapons? Because we have instances where they have firearms, and unfortunately they're not locked away. So that's not safe for us to enter their house. So we can't go to their house at that time. And we've also had people who didn't want to disclose, and that's not safe for us. So, we couldn't sign them on, but we also have patients who do have weapons and they are locked away. So just making sure that when whoever's going into the house, whether it's the couriers, the nurses, whoever's going into the house is safe in that house and their environment, because you're being taken out of your own safe place and environment in the hospital, and we're being put into somebody else's home that, we've never been to. Do they have pets? What kind of pets do they have? Can they put them away while we're there? So all of that kind of stuff we do have to ask and screen before we sign them on to make sure.
Yeah, because safety is important for our patients, but it's important for our team as well. Right. So, we don't ever want to put them in a situation. And, we look at areas that are safe at nighttime. Is it best to try to have a visit before it gets dark in that area to keep our nurse safe? Our nurses carry panic alarms. If they need to, there's a panic alarm that'll alert the system and send out a message that we can get help. So there's a lot of different things that we do to make sure that this is working. So that's all the stuff. When I say safest, that's the background behind it. All right, let's see if I can try to do this first, and then we're going to share, and then we're going to share the audio so everybody hears.
Hospital from Home, we make sure that you get the same hospital care in the comfort of your home. Once you've consented for Hospital from Home and we've identified that you're a great candidate, our team will meet together. We'll make sure that we are getting all the equipment necessary to your home. We will let you know what time the equipment will be delivered. A nurse will be to your home to set everything up, make sure you feel comfortable checking your vital signs, make sure you will understand the process and your plan of care. It can be a little overwhelming the first day. You're going to have all of the equipment delivered to you. You're going to have the technician set everything up. Your nurse will explain everything and tell you what the process is, what to expect. You don't need to be tech savvy to do Hospital from Home. All of our technology is very simple, just a touch of a button, and our team is always available to help you if you need it. But once that first day is over, people generally feel very comfortable the next day with everything. And even if you have any questions when your nurse leaves, you always have your virtual nurse available at the touch of a button to answer any questions you have. I usually tell my patients to expect at least 4 knocks on the door a day. You're going to have 2 visits from your nurse, 1 from a courier delivering medication, and if the doctor orders blood work, which we can do with Hospital from Home, you may have a courier come to pick up the blood work to bring it back to the hospital to be tested. Your virtual care team consists of your registered nurse and your doctor. They're available 24/7. Your nurses will call you in the morning to check on you, and you'll get at least 1 call from your virtual doctor every day to check in on you and talk about your plan of care. When you get home, your nurse will take pictures of all of the medications that you take. This is so the doctor can ensure that you get everything that you need. Also, just secure those medication and put them away because everything that you're going to take is going to be delivered from our pharmacy. So you'll have everything that you need prescribed by the doctor for 24 hours every day, and you'll get a delivery of that once a day. But if you need any extra supplies upon discharge, our team will make sure that you have that. Nutrition is an important part of your care. So with Hospital from Home, we make sure that you get those meals in the form of frozen meals delivered to your door. Every day, our team gets together to make sure that you're getting the best care that you can. Our nurses, doctors, and care coordinators all discuss your plan of care to make sure your care is safe, it's efficient, and you get everything that you need. Once you're ready to be discharged, just like in the hospital, our team will print out your discharge instructions, which you can also access through MyChart. We'll take out your IV, and our team will come and pick up all of the equipment, and your home will be just like it was before we came to take care of you. If you have any questions about Hospital from Home, a number will be provided for you, and our team is happy to answer any questions that you have.
Hopefully that helped a little bit with some of the things that happen. I know we gave you a lot of information. I have one more video if you'd like to see it of a patient that explains why he was happy on Hospital from Home. Give me 1 second, I'll pull it up. And we'll take any questions that you guys have too.
I have a question for you.
Yeah, absolutely.
When I was doing my externship in the summer, I went with one of the nurses to Hospital from Home. And at that point, you did it with an outside providers. It was done like from Texas. It wasn't done from Jersey Shore, like the doctors and all that. Did that change yet, or is that still going on?
It did not change yet, but I can say that I believe that the future plans will be to change. However, there's going to be a little bit of time associated with that because it would have to be built. We have partnered with this company, so there's some contracts and things that'll happen. So I believe, and my firm belief is within the next 5 years, we would probably internalize everything.
Right, because they said they used to do it and then they didn't, so.
Right. So what we did as part of the pilot when we first started it to see how it would work and if we would have the patients and the buy-in and the things that would have to happen to really put the program into place, we did do it. And I'll say that there were positives with that, meaning that, we had a lot more control of the scheduling piece and what time the nurses went out and medications, et cetera. But as you try to increase your volume, your nurses really need to be in the home more versus doing those other aspects. So, partnering with this company allows them to help us do that and put the nurses into the home and really focus more on the patient. So, when you think about the volumes that we talked about, in a year and a half, we had 67 patients total in a year and a half in our own program where we did everything. We have 238 in less than a year by partnering. So it allowed us, absolutely. It allowed us to cover, we went from a 10 to 15 mile radius to be able to cover 25 miles from Jersey Shore. So we have gone to Lakewood, Toms River, Jackson, Atlantic Highlands, Little Silver.
We drove all the way to Manchester, like from.
Yeah, right. So it really has allowed us to incorporate more patients in a larger area to be able to service more people. We've gone up to Old Bridge in the summer, May of last year, I think it was. We went all the way up to Old Bridge.
I think we went down to Beechwood.
Yep. So it really has allowed us to expand, and again, it's all part of the growth and the fact that they continue to add on to our other hospitals. I do believe that the goal would be to have our internal command centers, that we would do things on our own here. And that's what my hope would be. So.
Got it. Thank you.
Oh, you're welcome. How was your experience when you went to the homes? What was your thought on it?
It was really beautiful. Besides for I know you mentioned that it has to be safe and the dogs have to be locked up. It wasn't, of course. So that was my first house we went to. They ended up having to lock it up because I was petrified to walk in. Right. But other than that, it was really beautiful. When you say it's overwhelming, it was overwhelming when we did our admission. Like the first patient, they would just come from the hospital and all the equipment and everything. And the guy brought the oxygen. The guy was hysterical. He's like, where are you putting it? There's no room in my house. It was a tiny little house. You have to find room for everything. we were there when the equipment was delivered, so it was good. Like, we were able to like talk to them and all that, help them transition. It was really interesting. So I got to do the admission. We did it like discharge as well. It was nice. I think it was beautiful for the patients, but they definitely need to have the support. Like, they have to have a spouse, they have to have children. Like, there has to be someone at home to help them take care of them. They can't do it if they're not capable.
Yeah, it can be overwhelming. And again, that's why we go through the screening process, and we might have 200 patients to sift through today and we found nobody, right? Because of these things. So it really can be challenging, but we try to support the best ways that we can, like putting in that home health aid if needed, if we identify that, you know, or the live-in if they would have it, et cetera. So,
And there's been
Very
times
nice. The patients love it. So it was
yes,
really nice.
they do. And at the end of the day, our goal is, right, always to make sure that we're doing what's best for the patient, right? Every person that goes into healthcare wants to help somebody and wants to do the right thing for the patient. So, you know, to be able to see it work in action, it's overwhelming when we throw slides at you and we show you videos and like see it. And until you actually experience it, it's very different.
Definitely. Thank
And
you.
thank you for sharing.
No, I was just gonna say that there's been times where, you know, those kind of instances where you get home and you're realizing that, you know, how the patient portrayed how home was and everything wasn't actually what's kind of going on. So we've not gotten a home health aide at the beginning, but then we went into their home and they're like, they would benefit from a home health aide. So then we would try to get one for them while they're at the home.
Yeah, and our screening tools allow us some insight, but we don't have someone that goes to the house to check it out first, right? So when we talked about safest for the patient and safe care, we sent somebody home, and upon delivery, you know, we asked, do you have clear paths to walk in? That's part of the screening. They didn't really have clear paths. It was literally a very narrow path. And then when they went to go put the equipment in the home and plug it in, they saw that there was a burnt outlet. Right. So that at that point is not safe for us to use our equipment, and it's not safe for the patient. So the patient came back, and, you know, we asked the patients of sound mind and can make her own decisions. And we said, do you want us to help you, like reach out to your apartment company to have them fix it, et cetera? And she's like, nope, I'll do this all on my own. But at that point, she understood that we couldn't keep her in her house, you know, to give her the care that she needed, because it really wasn't the best situation for her living wise. And you have some challenges because some people, that may be their lifestyle, right? And it's just different. But what is the safest thing for them at that time, and how are we going to manage that?
And I remember with her, her father just passed, so they were selling that house, her father's house. So she had a lot more stuff than normal, but she also kind of did have a lot of stuff piling up in the house. So,
yeah.
We brought her back and she was okay here. But we tried, you know, that's the number one thing. You know, we try, and we did offer services. And that's another thing that happens when you go into the home, is that there's some things where you're in a hospital you don't see, but you're in a patient's home and you see some things that they might need help with. And you can get social work involved at that point, where if they were in the hospital, we wouldn't have, like, that wouldn't have opened our eyes to anything that they needed help with.
One of the other things that we've noticed too, like the cost of medications. So when you're a nurse in the hospital, you're going and you're discharging your patient and you're giving them the script and you're saying, good luck to you. I hope you feel better. Get your script filled. These are your instructions, et cetera. We get to see sometimes how much of a challenge it is to afford some of these medications, such as your Eliquis or your Brilinta, et cetera. Difficid for C. diff, Zyvox. You know, some of those are really costly, and how can we assist in making sure that they're going to be compliant and getting that? Because you could give them the script, but if they can't afford to fill it, they're not going to take the medication. And then what happens? There's a readmission risk, right? So we actually have a little bit more insight to what's going to happen after their discharge and can play a role in that piece. Chrissy and I do follow-up calls too to see how patients were. See what they need, if there's anything that we can do to help support them, were they able to fill their prescriptions, et cetera. So it's really nice to be able to follow up with the patients. And I round on them. I video chat them too, just like they were in the hospital. As a leader, I would go into their room and ask, you know, how are things going? Is there anything I could do for them? Things that we could do better. And it allows us insight into the program and how to make it really excel. And I know it's 11:30, so Dr. Wormser, I'm sorry, I think I went over my time, so I won't show you the last video, but any other questions that you guys have?
Thank you so much, and Christine, I really appreciate it. You really gave a great overview of the program. I have a couple of questions. So the doctor would never visit the home, correct? Because you haven't out.
Yeah, the doctors don't go into the home. They'll do virtual, so they get a link that gets sent to them from the command. Like the providers that are the virtual hospitalists have access to the patient every day and can go into the tablet and pop up on their screen and do their visit. Our consultant will receive a link. So our infectious disease doctors will say, all right, I'm going to set my time for 2:00 to see this patient. And we send, they get sent a link to log in, and the patient's there on the screen, and they can do that. If somebody needs to be seen physically, then they get brought back into the hospital. And we've done it where they get brought to like a temporary bed in the Care Transition Center, or if they need a further evaluation, they actually get bedded on a unit.
And then once they're discharged, can they go on to home care?
They can. So we are social workers, just like a regular discharge from the hospital. Our social work is involved in the plan of care. They do our MDR rounds. We do a daily MDR multidiscipline rounds at 10:30 during the week and then 11 a.m. on the weekends. So any oxygen therapy needs that would be needed to continue after discharge, the case management and social work team work on home care. If there's home PT that is needed, that all gets arranged prior to their discharge. And essentially, we say we're discharging you to home, but they're already in their home. They're getting discharged and released from the program. On the program, I didn't tell you in the beginning, you're not allowed to leave your home, right? Because you are hospitalized. So we expect you to be just like a hospitalized patient. You're not going to leave the hospital. You're not going to leave your home. So it is a little bit tricky. We always say you can't get your hair done. You can't go out to eat with your friends, but your friends can come to you. Because you're essentially still in the hospital. We took the hospital walls and put them in your house.
That's great. And then one final question about your outcomes. I'm sure you're tracking them. I imagine that infection rates are way lower for this population. Do you have?
So our hospital from home with Jersey Shore particularly, we have, knock on some kind of formica, we have not had any hospital-acquired infections at this point.
Wow, that's great.
And we do have patients that have PICC lines or central lines, midlines, Foley catheters, et cetera. So, we still do the same things that we do in the brick and mortar with that CHG bath. Our nurses are doing the CHG bath in the home, and they're doing that Foley care in the home. And you're actually allowing to teach the patient how to do it too. So they're getting great education.
That one-on-one time.
Yes.
No, very exciting. Thank you so much for taking the time, and I'll be in touch again with my next graduating class.
Absolutely. And thank you for having us. Thank you for your time. Congratulations to you. I know senior year, you've gone through a lot to get here. So just keep your heads up, stay strong, and just know that you do make a difference. And we appreciate you following along and going on these ride-alongs with our nurses and seeing how this program works.
And we do have a graduate of ours, Kelly Sattler is one of his, yeah.
So that was the video I was trying to show you with Leon.
I know. I saw the video. That's okay.
Yes. Yeah. We're very proud of all of our nurses. They speak up for their patients. They're true advocates, and really I couldn't ask for a better team to help make this work. So I'm very proud of each and every one of them.
Okay. Well, thank you again, and I'll be in touch. Thanks so much.
Great. Have a great day, guys. Take care.
Okay. So thank you for your attention and for being great participants. And did you enjoy the presentations?
Yes, thank you. They were really informative.
Okay. So you will be reporting on each of the presentations in your reflection that is due at the end of next week. And I think we're going to be heading into Passover and Easter shortly. So have wonderful holidays. Good to see all of you.
Thank you very much.
Thank you.
Thank you.
so much.
Bye-bye.
Thank you.
Bye-bye.